Bronchial asthma. It's a chronic inflammatory airway disease characterized by periodicity and diurnal variability of symptoms, airway hyperresponsiveness to wide range of stimuli, and reversible airflow limitation, which can be reversible spontaneously or with treatment. Airway obstruction occurs due to combination of smooth muscle contraction, airway lumen secretions, and edema of bronchial mucosa with accumulation of inflammatory cells. It can be irreversible over time due to basement membrane thickening, collagen deposition, epithelial damage, or airway remodeling, which occurs in chronic diseases with smooth muscle hypertrophy. Classifications. We have extrinsic asthma and intrinsic asthma. Extrinsic asthma, the environmental inducing agent can be identified. It occurs most frequently in atopic individuals and the onset usually in childhood. Frequently associated with other atopic diseases such as atopic dermatitis and allergic rhinitis. Intrinsic asthma, no causative agent can be identified, starts usually in middle age, late onset, and not associated with other atopic diseases. So if we're going to compare between extrinsic and intrinsic asthma, the age of onset, childhood in extrinsic, middle age in intrinsic, precipitating factor is obvious in extrinsic but not obvious in intrinsic, family history, in extrinsic is allergy, while in intrinsic is bronchial asthma. Atopic tendency is usually apparent in extrinsic, while it's absent in intrinsic. IgE level is raised in extrinsic with positive skin test, while in intrinsic we have negative skin test and not raised IgE level. The asthma is intermittent in extrinsic, while it's less labile or severe in intrinsic. The allergens causing asthma are house dust mites, animal hair, bird feathers, pollens, fungal allergens such as aspergillus, and rarely foods. The triggers of asthma attacks are allergens, air pollution, smoking, chemical oxidants released from motor vehicles, respiratory infections, especially viral, iatrogenic, aspirin and beta blockers, occupational, due to agents at workplace such as isocyanates, woods, formaldehyde, latex, cold air and exercise due to histamine and leukotriene released from mast cells caused by post-thermal changes. Pathogenesis, immunological mechanism, neuronal mechanism, and genetic factor. Genetic factor plays a major role in regulation of IgE production. It's a polygenetic disease, chromosome 5, 2, and 20, 5 for genes controlling production of cytokines, 2 for genes controlling IgE synthesis, and 20 contains gene called ADAM33, which is strongly associated with airway hyperresponsiveness and airway remodeling. ADAM33. So we have the neuronal mechanism. Parasympathetic causes bronchoconstriction and increase in mucus secretions, while sympathetic stimulation causes bronchodilation. Then we have non-adrenergic, non-cholinergic factors such as neurotransmitter called vasoactive intestinal peptide, VIP, leads to bronchodilation. Deficiency in this system leads to bronchospasm. The immunological mechanism, exposure to specific allergen leads to stimulation of T helper cells, leads to production of IgE bodies. This is called sensitization. Following sensitization, repeated exposure to allergen leads to antigen and antibody reaction on the surface of mast cells, leading to disruption of the cells and release of chemical mediators, which are short-acting chemical mediators such as histamine, bradykinin, leukotrienes, prostaglandins, and eosinophils, which cause bronchoconstriction, the immediate phase, while there are other mediators released called long-acting mediators such as platelet activating factor and major basic protein, leading to edema and cellular infiltration of the bronchial wall, which is called the late phase of the bronchial asthma. Then we have a clinical picture. Symptoms: recurrent attacks of wheezes, shortness of breath, chest tightness, and cough. Symptoms worsen at night, early morning, after allergen exposure, exercise, cold air, upper respiratory tract infection, and there is positive family history of asthma or atopic diseases. The signs: in between attacks there are no signs, but during the attacks we have hyperinflation of the chest with increased anteroposterior diameter, wheezing, which is most marked in expiration, the most characteristic breath sound of asthma, but it's an unreliable indicator of severity, vesicular breathing with prolonged expiration due to bronchospasm, tachycardia, tachypnea, and working accessory respiratory muscles. Complications of asthma: acute severe asthma or status asthmaticus, pneumothorax, psychological troubles, respiratory failure, cor pulmonale, complications of cough, such as fracture of ribs, side effects of medications such as arrhythmia. Then we have investigations: pulmonary function tests, chest x-ray, detection of allergen, blood picture, blood gases, sputum, and ECG. ECG to exclude cardiac causes of dyspnea. Sputum examinations: we have eosinophils in the sputum, Kirschmann's spirals, which are white, yellow, long threads composed of epithelium, eosinophils, and mucus, casts of distal airway, Charcot-Leyden crystals, breakdown products of eosinophils, and Crayola bodies, which are clusters of columnar bronchial epithelium. Blood gases: in acute severe attacks, there is decreased oxygen pressure with normal carbon dioxide. Increase in carbon dioxide is a very bad prognosis and considered indication of mechanical ventilation. Blood picture: eosinophilia, more than 400 per centimeter square, which may be present in allergic cases. We have leukocytosis due to infection. Then, detection of allergens by skin prick test, which should be performed to help identify the allergic cause. Specific bronchoprovocative test can be used using inhaled antigens. Chest x-ray is not diagnostic for asthma, and we can find normal chest x-ray, but it's done mainly to exclude pneumonia, pneumothorax, or shadows such as allergic bronchopulmonary aspergillosis. Pulmonary function tests: this is a cornerstone of diagnosis. It may be normal between the attacks, but mainly we have reduced forced expiratory volume 1, FEV1, and the ratio between FEV1 and FVC during the attacks is also reduced. The test of reversibility or bronchodilator test improves the FEV1 by more than 15% after inhalation of short-acting beta-2 agonist. Unlike COPD, the FEV1 response is less than 15%. Response to bronchodilators may not be present in severe chronic asthma when little reversibility can be demonstrated. And we have significant diurnal peak expiratory flow rate, PEFR, variability, more than 20% on at least 3 days per week for a minimum of 2 weeks. Bronchial provocation test using histamine, methycholine, or exercise to induce airway hyperresponsiveness. Then we have classifications of degree of asthma according to severity. We have 4 types: mild intermittent, mild persistent, moderate persistent, and severe persistent. Mild intermittent occurs for 2 days or less per week and 2 nights or less per month, with PEFR or FEV1 more than 80% and PEFR variability less than 20%. The mild persistent occurs for more than 2 days per week but less than once per day and more than 2 nights per month, with PEFR more than 80% and PEFR variability from 20 to 30%. The moderate persistent occurs daily and more than 1 night per week, with PEFR from 60 to 80% and PEFR variability more than 30%. Severe persistent is continuous and frequent, whether during days or nights per month, with PEFR less than 60% and PEFR variability more than 30%. The differential diagnosis: we have for other causes of wheezing, other causes of paroxysmal dyspnea, and then we have drug-induced cough from ACE inhibitors and vocal cord dysfunction, fastidious asthma. Other causes of wheezing are COPD, cardiac asthma, carcinoid syndrome, which is associated with stridor, not wheezing, Churg-Strauss vasculitis, and upper airway obstruction due to foreign body tumor or laryngeal edema. All that wheezes isn't asthma, and all that glitters isn't gold. I'm sorry. For other causes of paroxysmal dyspnea, we have tetany, myasthenia crisis, recurrent pulmonary emboli, and hysterical dyspnea. Treatment: the components of treatment are patient and family education, assessment and monitoring of severity, environmental control and avoidance of risk factors, establishing individual medication plan for long-term management and for managing of exacerbations, with providing regular follow-up. The goals of treatment are for prevention of exacerbation, avoidance of adverse effects of medications, prevention of irreversible limitation, with aiming for no symptoms or near normal lung function on minimal treatment. The treatment is divided into pharmacotherapy and immunotherapy. Immunotherapy, desensitization, allergen immunotherapy is indicated when there is a clear evidence of relationship between symptoms and a specific allergen, or when there is a poor response with pharmacological therapy. Pharmacotherapy. It differs according to the different types of asthma. For mild intermittent, during the attack, we induce short-acting beta-2 agonist, salbutamol inhaler. In mild persistent during the attack, we induce also short-acting beta-2 agonists, so step 1 and step 2 are the same. But for step 3 and step 4, we add anticholinergic drug, ipratropium bromide inhaler, with the short-acting beta-2 agonist. In between the attacks, the mild intermittent receives no medication, whilst mild persistent receives low-dose inhaled corticosteroids, 500 microgram or less in the dosage, such as beclomethasone dipropionate, and long-acting inhaled beta-2 agonist salmeterol, chromones, disodium chromoglycate, antileukotrienes such as Singulair, and sustained-release thiophelin. You need to know that there are 4 things we give in between the attacks, and they are given in the mild persistent, moderate persistent, and severe persistent, which are thiophelin, antileukotrienes, chromones such as disodium chromoglycate, and long-acting inhaled beta-2 agonist. But they are gonna differ in the dosage of the inhaled corticosteroids. For mild persistent, we give low-dose inhaled corticosteroids, 500 or less microgram, while in moderate persistent, we give medium-dose inhaled corticosteroids from 500 to 1000 microgram, while in severe persistent we give high-dose inhaled corticosteroids more than 1000 microgram. Then we have the pharmacology of the drugs. The drugs are divided into reliever drugs and controller or preventive drugs. The reliever drugs are the short-acting bronchodilators. They aim to relieve the patient during the attack. We have short-acting beta-2 agonist, anticholinergic drugs, and methylvancins, thiophelin. Short-acting beta-2 agonist, salbutamol and terbutaline. Salbutamol 100 microgram inhaler, 2 puffs as needed. Terbutaline is 250 microgram, 2 puffs as needed. Stimulation of beta-2 receptors leads to bronchial smooth muscle relaxation. Aerosol delivery of these drugs provide more rapid onset of action and less side effects than the oral delivery. Side effects are tachycardia, tremors, glaucoma, and hypertension. Anticholinergic drugs, ipratropium bromide inhaler, they are non-selective antimuscarinic agents. They may be added with beta-2 agonists, especially to relieve asthma exacerbations. The major disadvantage is that they are slowly acting drugs from 60 to 90 minutes to reach their peak bronchodilation, and that's why they are given with short-acting beta-2 agonists. Methylvancins or thiophelin, they are of bronchodilator effect. They can be given orally, suppository, or slowly IV infusion in severe cases. And recently they are used in the controller class. They are used as long-acting drugs to guard against nocturnal asthma, and the IV route is used in severe acute asthma. Side effects are gastritis, nervousness, headache, arrhythmia, and convulsions. Wide range of drug interactions. Smoking and phenytoin increase its clearance, while erythromycin, cimetidine, and propranolol decrease its clearance. This is a very important MCQ note. Controller and preventive drugs. They are used in between the attacks, taken on long term, aiming to control the disease. They include anti-inflammatory agents and long-acting bronchodilators. Inhaled corticosteroids are at present the most effective controllers. They are divided into inhaled corticosteroids, systemic steroids, chromones, antileukotrienes, long-acting beta-2 agonists, and anti-IgE. Anti-IgE omalizumab, humanized anti-IgE antibody. It's given subcutaneously every 2 to 4 weeks. Long-acting beta-2 agonist, salmeterol, formiflor, they are given by inhalation, and they can be given with inhaled corticosteroids. Antileukotrienes, montelukast or Singulair, it's very effective. Chromones, such as disodium chromoglycate or nidochromyl sodium, they are administered only by inhalation. Their major therapeutic effect is to inhibit degranulation of mast cells to prevent the release of chemical mediators. They were previously called mast cell stabilizers, but this term is now obsolete because they can have suppressive effect on eosinophils and macrophages. The role of therapy: they are most effective in atopic patients and in exercise-induced asthma. Systemic steroids, oral steroids such as prednisone and prednisolone, injected steroids, hydrocortisone and dexamethasone. The dose should be kept as low as possible to minimize the side effects. Inhaled corticosteroids. The anti-inflammatory effect of corticosteroids decreases airway inflammation, hyperactivity, and exacerbation. We give biclomethasone dipropionate or fluticasone propionate. Side effects are dysphonia and oropharyngeal candidiasis, which is avoided by mouth washing after use. Acute severe asthma. Definition: it was previously called status asthmaticus, which is asthma that had failed to resolve with therapy in 24 hours, but this term is now discarded and replaced by acute severe asthma which hasn't been controlled by the patient's use of medication. Clinical picture: symptoms: anxiety, breathlessness at rest, sweating, and difficult speech. The patient is unable to complete sentences in one breath. Signs: increased respiratory rate more than 25 per minute, tachycardia more than 110 per minute, pulsus paradoxicus in some patients, inspiratory fall of systolic blood pressure more than 10 mm mercury, chest auscultation, inspiratory and expiratory wheezes, with PEFR 33 to 50% of predicted. Criteria of diagnosis: for acute severe asthma, we need any one of those. For PEFR from 33 to 50%, respiratory rate 25 or more, heart rate 110 or more, and unable to complete sentences in one breath. But to diagnose life-threatening asthma, we need to find any one of those clinical signs or measurements. For clinical signs, we have silent chest, exhaustion, arrhythmia, low blood pressure, cyanosis, altered level of consciousness, and poor respiratory effort. Measurements: we have PEFR less than 33%, oxygen saturation less than 92%, oxygen pressure less than 60 mm mercury despite treatment with oxygen, and normal carbon dioxide pressure. For near fatal asthma, we need to have high carbon dioxide pressure. Fatality in asthma is due to cardiac arrest secondary to hypoxia or acidosis. Treatment of acute severe asthma: we have 6 items: oxygen, short-acting beta-2 agonist, hydrocortisone, aminophylline, hydration, and mechanical ventilation. Oxygen therapy: 60% is given to maintain oxygen saturation above 92%. Short-acting agonist, which is the first line of therapy, very important MCQ note, salbutamol is given either parenterally or inhalation, but the inhaled forms are superior to the parenteral route because it has fewer side effects. The parenteral route is reserved for patients who are dyspneic and can't take deep enough breath. Hydrocortisone: 100 mg per 6 hours for the first 24 hours IV, then prednisone 60 mg orally should be given for 2 weeks daily, then gradual tapering. It should be given as soon as possible because the peak onset of action can take 4 to 6 hours. Aminophylline: slow infusion over 20 minutes with careful monitoring because it can induce asthma and other undesired side effects. But IV aminophylline in treatment of acute severe asthma is a bad choice because several studies showed that it's of no benefit. Hydration: plenty of oral and IV fluids. Potassium supplements may be necessary because repeated doses of salbutamol can lower serum potassium. Mechanical ventilation: we have 5 indications: deteriorating PEFR, persistent hypoxemia or hypercapnia, exhaustion, confusion, drowsiness, coma, respiratory arrest, and previous history of mechanical ventilation.